I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is empowering unsheltered people. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan.
Hey, Faisel. It's great to be with you again this evening.
How are you doing?
I'm doing well. I'm looking forward to this conversation this evening. I know we've talked about it in the past, but to be in such a wealthy country and have so many people who need so much, having a way to help them seems like a great idea.
Oh, I love the innovators. And tonight we definitely have an innovator who came up with a wonderful idea, and I can't wait for him to share the story about how he came up with his app and the impact he's been able to make by helping the homeless. So without further ado, let's welcome our friend for the evening, Jonathan Kumar. Jonathan, welcome.
Hey, thanks for having me, Faisel, and Dr. Dan. Good to be with you as well tonight.
Yeah, I was so impressed that with your app and what you've been able to do with allowing people to just help those who are homeless, those who need services just from an app. But before we get into your app, I'd love to hear your story. I remember we had our conversation a couple months ago, and I'd love for you to share that story.
Yeah, thank you. I'm glad to share and even take it before my story. My parents were immigrants in the late 80s from South India. They got an opportunity to move to Buffalo, New York, where I was born, and my dad was studying at the time. My mom wasn't working, so the three of us actually were living off of a student stipend of about $600 to $800 a month, which at the time went much further than it does now. But I was born in a public hospital, and my mom had delivered me naturally, even though I was 10 pounds 10 ounces, because the doctors did not want to provide a free C-section, and it was just horrible. That created some significant medical problems for my mom. We were in public housing. We were on Medicaid, food stamps, WIC, all of those things. We were definitely food insecure, though we were never homeless. And I mentioned that because there was a group of people from a church, actually, that sort of adopted my family and provided socially, provided financially for my folks and myself, until my dad graduated, got a job in Madison, Wisconsin, moved the family. And I'll tie back Samaritan to that situation in a few moments. But fast forward 20 years, lived in Madison, lived in the Chicago area, went to the University of Michigan, studied user experience design, helped start a company out of college. We were scaling that startup from Michigan to Washington State in Seattle in 2015. And long story short, we ran out of cash, we ran out of funding and fuel, and I was looking at what my next step was going to be, whether work at Google or an ad agency or somewhere else in big tech. And I just noticed how pervasive people were that were living on the sidewalk or panhandling or standing in line for food or for shelter. And, just with some of the values that I had been brought up with, I wanted to better understand their user experience. I wanted to better understand, where they had come from to be in the situation they were in, experiencing homelessness, where they were trying to go and what the barriers were for them to get there. And so, I sort of went directly to the source, and I just started having short but meaningful conversations with as many people as was practical. The summer of 2015, so this is a long time ago now.
Was this in Seattle?
That's right. Sorry, yeah, this is in Seattle. And so after moving to Seattle for that first startup, I stuck around after that company basically went on ice, and then was spending time with people on the street, just hearing, again, the barriers they were up against to moving forward and how they had come to the streets in the first place. And there was this sort of common denominator that I identified in that it seemed that whenever the event that led to someone's homelessness occurred, whether it be a job loss or rent being doubled or a situation of domestic violence, substance use, mental illness, whatever it may be, that there was a lack of a team or a lack of a social safety net to really keep that person afloat. And with a lack of a network that person trusted, that person, ended up on the concrete. And, I tie that to, my parents' situation because, we were given that team and we were provided for until my dad was able to get on his feet. And I know that today, if I had, developed a substance use disorder or had lost my job or whatever, that I would have friends and family to keep me from losing my housing. But absent of that, that's kind of what would lead people to the street. So that, was sort of the identification and of the issue, this lack of social capital or this, sense of relational poverty, that sort of led me to want to learn more and maybe start doing something around, creating value for this population.
Wow. And so how did you, where did the idea for the actual app, how did you, how did you put the team together? I mean, you got to get the device, you got to get the hardware, you got to figure out, you got to build relationships to be able to, to be able to provide these supports. How did you put that team together?
Yeah. I remember in terms of the solution, there was a person in particular that I met on the street, and it helped me sort of synthesize what I could develop to add value to people without stable housing. I was on a lunch break at my old startup still, and I was having a sandwich outdoors in a rare nice day in Seattle. And he was at a intersection about 50, 75 yards away, panhandling. And I noticed for about 15 minutes maybe 20 minutes that not a single window open to him passing by. Not a single person seemed to even acknowledge that he was there. And, he was clearly visible to me, but he seemed to be about invisible to everyone else. And so I finished my sandwich and I went up and I went over and I talked to him, and his sign, I got closer and I read his sign, and his sign, and I used to have it. I think it was thrown away recently by my wife finally, but it read, need medication for the diabetes in my feet. And he stood there gingerly holding the sign. And so I walk up to him and I ask him, excuse me, sir, wanting to understand, some of his challenges. Do you mind if I ask you what you feel your struggle is in terms of raising the money that you need? You feel people aren't carrying cash on them these days? And he cut me off. He basically said, I've got the wrong look for this, the wrong skin color, the wrong clothing. Nobody actually believes I am who I say I am. And, you know,
Wow.
yeah, I mean, my heart broke in that moment. That I sort of stumbled this next question. I was like, well, you know, if you don't have any money, you shouldn't have to pay for this medication. Do you have access to a doctor or a physician that could get you this medication for free? And he said to me, yes, I have a doctor through the shelter I'm staying at, but he gives me about a fifth of what I need to manage the pain. And he doesn't trust me with anything more than that because he thinks I'm going to sell it or get addicted to it. And, you know, just so heartbreaking as I realized that this person, Edward, you know, had no real way to communicate his true identity, his true needs to people passing by or providers who well would have been able to or willing to help if there was a clear and effective way to do so that was very, very easy and transparent. And then so you know, armed with these types of conversations, Faisel, I started sort of synthesizing this support platform that would allow people to join the team of people like Edward and, you know, learn their story, invest either time or money or both to help people like Edward meet needs and take steps towards you know, stability in their life. You know, typically finding housing again, raising their income level, helping them access primary care, things of that nature.
So people like Edward, they have insurance. I mean, I would imagine he had Medicaid.
Most do, maybe 75%.
And so how, you know, this back again to the idea of the beacon. Like, how did the beacon, like, how did you get the beacon made, and then how does that work with the app?
Yeah, great question. So I guess it's time for me to explain what the heck Samaritan actually is.
Yes, we could get into that. I mean, I love it. I love what.
Yeah. I love this story too. But yeah, now we're talking about the necessary evil of technology to drive, you know, the social and financial capital that these people are lacking for them to, you know, reach housing, life, health goals. So we provide these smart wallets called beacons, Bluetooth beacons to health and human services to offer as a resource for you know, people without stable housing that they're serving. If someone becomes a Samaritan member, which is free for them, they get one of these smart IDs which run on Bluetooth and can securely store and furnish critical documents that person has, you know, vaccination cards, work permits, court documents, ID cards, insurance cards, and can store and help that person spend money. So the person gets one of these things in a street outreach context or case management, housing navigation, a community health worker, and they're able to share Faisel some you know, top level goals that they have for their life, and then break those goals down into needs and action steps. And then really from there on the back end, we're curating these teams of good Samaritans in communities. You know, we're partnering with churches or companies or civic groups to encourage everyday housed resourced residents who are not masters in social work, who are not experts in substance use or mental illness or physicians or anything like that. We're equipping everyday individuals to join the team of a specific Samaritan member through the Samaritan app, and to simply, again, learn the person's story and either give time, you know, through sending messages of encouragement or jumping on a phone call with the individual, making community introductions, dropping something off at a shelter, driving someone to an appointment, or give money, help meet immediate or strategic needs that the person has to getting housed. So, we enable that team to come around an individual and help either relationally or financially through our app Samaritan. The beacon serves as a way for the person to, again, access their benefits, store their documents, and then spend that money at designated providers.
It's incredible. It's incredible. And so where can they log in? Are there places that they can go with the beacon?
Yeah, actually, we don't require any technology access for the family or adult experiencing homelessness. All they need is this necklace with a Bluetooth beacon. They can go into a community-based nonprofit that's using Samaritan, and they can check in easily, and they'll have their balance on here. The provider, usually a case manager, or a community health worker, housing navigator, will see the person's balance and can move that balance to whatever the person needs most. So that could be a move-in deposit. That could be a storage locker payment. That could be a cell phone bill. That could be an Amazon purchase. It could be a grocery store gift card. We have a lot of different methods for pushing that money to where it most needs to go. And then we also have a smart debit card now that even if the person doesn't have a bank account, funds can be moved straight onto the card, given to the individual, and then the individual can spend that anywhere debit cards are accepted to meet their needs independently. So we're really excited about that, and we have seen that when you give people this direct social and financial support, it's almost like basic income, right? With this social layer, with this social support, people are more likely to have to build the capacity, to have the hopefulness, to have the strength to pursue housing or to pursue employment, to receive entitled benefits, to start accessing primary care instead of having to go to the hospital or to the emergency room constantly.
Well, that's definitely a space I want to get into, is the impact you've had with hospitals in the Seattle area, especially the emergency room visits. But before we get into the emergency room, I want to talk a little bit about some of the relational support your members have received from the Good Samaritans.
Yeah, thanks for asking. One of my favorite Samaritan members from our pilot in Seattle, and I'll mention two stories. One of our favorite members, he was a Vietnam vet, struggled with substance use, homelessness, mental illness for years on and off. And he gets a Samaritan membership. He gets $132 from his team of Samaritans in like the first 10 days, which is actually higher than our typical take. He calls us 10 days later and he says, "Hey, turn my membership off. I'm not going to need it anymore." And, we're discouraged. We hear that from time to time. That's not the outcome we're looking for. And we're like, "Oh, so sorry, this doesn't work out. We'll turn it off. What happened?" And he's like, no, you guys don't understand. Like, this is a good thing. I have chosen to enter rehab for the first time. I'm going to be off the grid for 3 months. I'm not going to need this anymore. And the reason I'm doing this is just because of all of these messages I was receiving from these like strangers. These strangers just keep messaging me saying that they believe in me, and the fact that they want to invest in me makes me want to invest in myself.
Wow.
And he hadn't even spent any of the money. $132 was sitting there. We had to get it to somebody else. So that's just like the power of not just financial capital, but the social capital, or that social home concept. Another Samaritan member actually moved into the backyard and then eventually the basement of one of the Samaritans on his team. And he was able to spend 6 months recovering from the trauma of living outdoors, the trauma of being attacked and bullied at different shelters, and overcoming some depression and mental illness. 4 or 5 months later, he started working and he moved out in month 6 or maybe month 7 from that basement. This is during the pandemic, mind you. He was able to have a safe place to stay, and he was actually paying $100 a week for rent to the owner of the house. And then he got his own place, and he, he's independent now. He's working full time. So yeah, we're just thrilled to see stories like this happen.
It's when you're at your lowest point where words of encouragement, just even from random strangers, can help encourage you through those difficult times. And I just think it's just wonderful that you've been able to come up with this platform that can allow that. So many people don't even have that.
Mm-hmm. Yeah, I mean, everyone needs a team, right? Whether you're rich or poor.
It's like a community of help. Dr. Dan, as he's speaking, he has figured out a way to just generate this community of help. Do you have a lot of doctors and nurses that are involved with this, or what would you say the typical people are who are trying to help support those who need services?
Yeah, I mean, on the health services side, we have a couple advisors who are physicians, ED docs, because the downstream, if you can think of a hill, like at the bottom of the hill when it comes to unmet social needs like safe housing or food, transportation, social support. At the bottom of that hill is the emergency room, which is the only place that will always take them. And when you're exposed to the elements, when you're exposed to substances, abuse, pandemics, you're, according to United Healthcare, like 8 times more likely to show up to the ED or the hospital than a typical Medicaid member who's already a high-risk individual, and you're 30 times more likely to show up than a commercial member, like myself. And so the costs of care for these individuals are just astronomical, as you can imagine, and it can lead to all kinds of not just financial issues, but operational issues at hospitals, EDs, from clogged up throughput to physician burnout, degraded morale. And so the physicians that we are in touch with in Seattle and also down in Los Angeles have been very excited about could this intervention help people address needs outside of the hospital to reduce the need for and the dependency on emergency health care.
Dr. Dan, your audio is not coming through clear. For some reason, it's coming up garbled. Let's see if maybe try now. No, it's not working. Why don't you try to unplug it and just use the? You could try using the laptop microphone. Maybe that'll work.
Yeah, sounded kind of like a child mixed with Darth Vader a little bit there.
Hey, that's one of the fun things about doing this live. You just never know what's going to happen. And it's interesting what you mentioned about the emergency room, because at least pre-COVID, half of all medical care in the country was delivered in the emergency room setting at the emergency room rate, just in general. So as a country, half of medical care is delivered in the emergency room setting at the ER rate. So it's something like a pneumonia. I had pneumonia 3 years ago, and I was there for a couple hours in a standalone emergency room. Very basic chest x-ray, EKG. I had a bag of IV, 2 antibiotics, and Tylenol, and the bill was almost $10,000. And the insurance ended up paying like $6,800, $6,900. I took that bill to one of our clinics. I could have very easily received the same treatment at any of our centers, and the manager went through and said, okay, well, the IV is $1, this antibiotic's 40 cents, this antibiotic's 90 cents. She went through and she said, for us, the cost would be less than $7. And she said, if you throw in the cash price for 2 view chest x-rays, like $15. Really, it's less than $25. So yeah, I'd like to understand the impact you've had, because we know that a big chunk of medical care is unnecessary. That's delivered in the emergency room setting. It could easily be delivered in a setting outside of the emergency room. But when you're having people going to the emergency room because of home insecurity, food insecurity, issues with transportation, just having access to their medications or what have you. And I'd love to hear some of the impacts you've had in the emergency rooms in the Seattle area?
It admittedly is still early, but I'll mention, one very concrete use case that we are talking with a major health system in Los Angeles is around people experiencing homelessness with chronic medical conditions like diabetes. So you have individuals who need to get their dialysis treatments 3 times a week ideally. And then when they don't end up being able to do that, they end up in the hospital, and it costs 3 to 4 times as much for the health system to do it at the hospital versus at the clinic. So we're talking to the clinic docs, like how can we help people, build the financial capacity, the social capacity to actually access the clinic instead of the hospital. And so in our platform, like I mentioned, we have these sort of paradigms around setting top level goals and then breaking them down into needs and action steps. And our Samaritan members earn financial bonuses for taking action steps towards their goals. So, we have a mechanism to run contingency management and incentives, and we're not beholden to the same regulations and restrictions that health systems, when they try and do contingency management, can often run into.
Sure.
So, we can provide this social and financial support for a person to start accessing clinics for risk assessments or dialysis treatments a lot more frequently than the hospital itself. So we're pretty excited about that use case, and that kind of gets into our business model and how we scale. The impact so far in Seattle hasn't necessarily been tied to medical outcomes yet. We ran a pilot with 500 unhoused families and individuals through 10 different community-based nonprofits. And we saw that with even just $40 and a team of 4 volunteers per month, that 56% of that 500, so it's like 274 of those, measurably improved these SDOH quality measures that we were capturing. So that's quality of access to care or income, transportation, food, utilities, which would include like cell phone, clothing, bus fare, or of course housing, which is the big one. And so we have been able to so 56% improved one of those quality of life. I think it was like 10 or 11% actually got into a full-time job or permanent housing or an addiction recovery program. And so while at the time we weren't tied into any sort of claims or utilization data, there is plenty of existing evidence out there that has been published by Kaiser, United Healthcare, Harborview, City and County of San Francisco, that ties these social outcomes, these life-changing social outcomes, to medical outcomes. So we're basically proxying the two and saying like, hey, we are demonstrating proof of concept for the social outcomes, and that already has been tied to medical outcomes. And we're in the process right now of proving that the link between the two exists. But we have also now deployed Samaritan in Oklahoma City, Orange County, Los Angeles, Portland, and Denver. We are just about to release some data from the first year in Oklahoma City, which I'm really excited about. And yeah, continue to prove that this is a statistically significant way to help people address social needs, especially for populations that are earning less than $1,000 a month and are experiencing homelessness.
So have I got my microphone fixed now? Good. Okay. So we have a question. Ajoy Kumar, I'm glad you're with us again tonight, Ajoy. So this is truly a compelling story and an innovative app and portal. Really applaud your efforts in helping the homeless. How have you secured the beacon from data theft? We hear about all this data theft, and surely people would have other people to steal from than the homeless. But in our society, we tend to take advantage of the most disadvantaged. So how have you secured the data so that when people are making contributions, they know that it will be used for the intended purposes.
Yeah, so these get lost all the time. It's kind of a matter of when, not if. Unfortunately, given the circumstances, but we don't store any of this like the sensitive information on the physical device. It's in the cloud. We are a HIPAA compliant AWS hosted solution with some of the best security that's available to startups like us. And so we haven't had any data breaches to date. And constantly, as we try and work with bigger and bigger health plans or health systems, they're making sure that data breaches are not possible. So we're going through penetration tests, and we're just doing our best to make sure that nothing like that would ever happen, and nothing has happened to date to that end.
Well, that is great. I was hearing, I guess, two thoughts hearing this conversation, and they're pretty disjointed. So the one is that in a number of hospitals that do the indigent care, they actually get paid very well for doing indigent care. So they may not be interested in you helping people have less health care. That's the problem. We truly have a sick care system rather than a health care system. But then the other thing I was thinking about, I know we've heard how many at Faisel, I don't remember the figure, but how many people are basically one flat tire away from missing their rent payment or becoming homeless? And so it's this seems like a way to help people, because we don't know who's going to need that help next, and whether it would be a friend or family member that might need that. And so you could respond to either of those comments or talk about something else. Those were just a couple of thoughts I had listening to this conversation.
NPR talked about it last year that we're kind of at a brink of seeing homelessness in the U.S. radically increase, which is just horrible because of the pandemic. Something like 30 million people are going to be about one check away from eviction. So we already have overburdened health and human services, and it's only going to get worse. And unfortunately, I just don't think we can hire enough MSWs or licensed clinicians, social workers, or community health workers. We can't hire and outsource this problem away. I really truly believe that at some level the community has to become the counselors themselves and really take ownership of the problem. And we can be a part of the onboarding people to again simply join the team of someone without a home. My father-in-law always says, like, if everybody's doing something, then I get to do less. And I think that principle here is true. If we have a team of 30 people, everyone only needs to do one act of kindness a month for a family without a home, and that person is going to be taken care of largely. And the numbers are, we have a numerical advantage here. So hopefully that kind of speaks to one of your questions, and I think I might have forgotten the other one.
That's fine. We actually have a question from Dr. Sabrina Jesman that joins us on a regular basis from Japan. And she said, is it only in the USA or globally accessible? Have you ever thought about developing countries? And then she goes on to say, in developed countries, we say homeless, like in Japan also, but in developing countries, they are street beggars.
Yeah, I feel like, go ahead, Faisel. We're going
to are you thinking about going? I think it seems like there's so much that needs to be done in the United States, but again, there's so many needy people around the world. Have you thought about leaving the United States?
Yeah, in Japan and East Asian context, actually, it's really interesting, like how much more sort of collective and like communities are. I have heard that homelessness is relatively rare because if you have someone who is on the street, typically a family will at some point just adopt them, and they will become an uncle, they will become a grandfather, and they will be brought in. And I have actually heard that the Chinese government will fine communities if no family, like I think they maybe fine or in some cases even jail people from rich Chinese families unless they take people in and then just treat them like a father or an uncle or a grandfather. And I just think that's so fascinating and obviously imperialistic, but at some level it works, and you just see less visible homelessness as a result. So, I can't say that I'm an expert as it relates to housing insecurity in sort of East Asian context or really in developing context as well. I know that poverty looks pretty different in developing contexts than it does here domestically. Like, for example, you're never going to starve to death in the United States unless, you're doing something wrong. That's not probably the most sensitive way to say that, but, just by that matter alone, I think, global poverty looks really different than domestic. And so right now, as we look to scale and we're a team of 9 people right now, as we look to try and build our sustainability and our revenue, we're pretty focused on high risk healthcare here in the States. And as we grow and as we're more impactful, hopefully our capacity to look at other countries and other contexts of poverty will grow. But as it relates to homelessness, also mental illness, substance use, returning populations from incarceration, and sort of the overlap between these populations in the U.S. Right now, we have plenty to work on. If we get $1 billion from Mackenzie, Scott, or whatever, I'm sure we'll be looking at other countries quite soon.
Here's what I'd like to do real quick. We're definitely over on time, but I'd like to close with hearing about your plans to scale. And in an ideal situation, what are some of the couple steps that would allow you to be able to scale this idea? But let's first take a quick 20-second break. Would that be okay if we can close on how the plan is? Okay, let's take a quick 20-second break.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. So, Jonathan, thank you so much for sticking around. We are definitely way over time. We try to keep this always to half an hour, but this was just a wonderful story, and I thank you for taking the time to explain your personal story, how you came up with this app, how you have the device, this community of health that you're inspiring for anonymous people to just help each other with random acts of kindness. I mean, I just love this, and I know it's going to do wonderful things. But now, tell me a little bit about what are you doing now to scale? What would be ideal for you to take, like the next 1-2 critical steps in order for you to really let this thing take off? And I want to be there when that happens.
Nice. Yeah. Thank you. Thank you so much for asking, Faisel. So, yeah, I mean, we're looking to serve more lives. Jessica, our chief operating officer, and I sort of have set this vision around wanting to have helped 100,000 men, women, and children take steps towards stable housing in the next 10 years. And then to have the next 100,000 people signed up for a Samaritan membership when we hit that milestone. So that's a big goal from where we are now, which is about 1,000 Samaritan members. And so for us to be able to get there and serve people with significant social needs in more than 100 U.S. communities, probably more like 200 to get to that 100K goal. We are going to need to create some significant value for organizations that have access to this population. So we're looking at public, county, nonprofit hospitals. We're looking at Medicaid plans and in some cases dual eligible plans, so Medicaid, Medicare, and then we're also looking at straight human services. The incentives and sort of the mechanisms that drive decision making and investment into interventions like Samaritan are different for each of those 3 verticals, if you will. And so, you know, we're talking to folks in all 3 categories. And, you know, nonprofits can make decisions quicker, but they're also smaller and don't have quite the scale and that health systems and Medicaid payers do, which obviously have scale, but they're a lot slower to make decisions. So right now we have been given some significant opportunities in a handful of communities, and we're opening up a fundraising round in September, both to take advantage of those deployments and really hit it out of the park in terms of quality of life impact, you know, which is how we grow, how we do more business, how we serve more lives. And then we'll also be raising money to kind of make this transition from serving human services exclusively, which is where we started and where most of our, you know, licenses and contracts are kind of in that space, to, you know, high-risk healthcare, Medicaid, uninsured POPs, you know, whether it be fee-for-service or value-based care. I'm really excited about some of the value-based arrangements that we're driving with a couple folks on the payer side. But that's kind of a vague look at you know, how we're hoping to scale.
Well, those value-based arrangements is where the movement is headed. And
yeah,
let me know when you start looking into the Tampa Bay area. You know, the Tampa Bay area has probably the highest rate of homelessness in the country.
Wow.
Yeah, it's the reason I moved here after my residency training. Yeah, we have somewhere, you know, out of the Hillsborough County has now over 1.4 million people, and we probably have 17,000 people who are homeless, with about a fifth of them being children.
I'll mention one quick thing before, you know, we end the show here, in terms of how we work with providers, because I know there's a lot of providers on the call here. You know, an ED can basically refer people to a Samaritan membership or give out the Samaritan membership at the ED itself, which is what we highly recommend. So that would be a discharge team, a community health worker, and we can really take it from there in terms of either hiring Samaritan staff on the ground or contracting with a local organization that's on the ground already to help guide that person from the point they get their Samaritan membership to the point where they have accepted a referral out in the community with a shelter, you know, that's made through Aunt Bertha or Healthify, Unite Us, partners of ours. So we can basically provide Samaritan memberships to be given out at the ED, and then handle the ongoing care from there. Or if a provider has ongoing primary care or, you know, complex behavioral health and case management services, you know, we can make sure that that person stays within that web of appropriate care versus coming back to the ED so frequently. So, you know, we would love to partner with more providers in getting this resource out to people through emergency departments. And then payers, they can, you know, give us a list of people, and we know how to outreach. We know how to reach, meaningfully engage, and retain people over time, helping them address social needs. So, yeah, wanted to make sure I threw that out there. In case
yeah. And when we post this online, I'd love to put some links as well, so that people can understand and see the services that we're talking about. Yeah, of course, this is wonderful what you're doing. This is a game changer. Thank you so much for joining us tonight.
Yeah, thanks so much for having me. Good to be with you, pandemic style at least.
Yeah, we will definitely post. I mean, once we get back to normal and some sort of normalcy, I'd love to meet you in person.
Yeah, I love Tampa.
It's a great place. I've got a bias so far as Tampa is concerned. Well, Dr. Dan, what a conversation.
Yeah, it's a great conversation. I think it's great to hear somebody with a way to engage individuals to be able to help other individuals and really make good use out of the iPhones and almost a a beneficial social media presence, if you will.
Yeah, yeah. He saw people were just not even opening the windows. People were just driving past those who needed attention, needed help, and he's using the technology as an extension of random acts of kindness. I just love it.
Well said. Yeah. Thank you.
Well, that tends to happen every now and then.
Very articulate.
Well, thank you so much, Jonathan, and Dr. Dan. Thank you so much to our audience. Thank you so much for joining us tonight. For more information about today's topic and to explore career opportunities with ChenMed, remember we are on track to opening another 400 to 500 centers in the next 4 to 5 years. I mean, you're talking another 2,000 to 3,000 doctors at a minimum, plus all the people who need to support those doctors who are looking after the patients in the most underserved neighborhoods across the country. Please visit chenmed.com to learn about career opportunities. We believe access to primary care is a right, not a privilege.